Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice. In any situation, please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you're unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, welcome back to another episode of Glasses Half Full. Today we will be discussing putting the power in the hands of the patient. So as practitioners, we obviously try to do as much as we can to treat the patient to the best of our ability in whatever capacity we have, but we only have them for anything from 20 to however long it takes you to watch the
30
appointment.
maximum.
In Scotland, is 30.
But even then, like if it's a referral or something, it might take a little bit longer. But the point is, we only have them for a very small amount of time, and the holistic eye health and taking care of yourself and your eyes is an everyday thing, or it can be an everyday thing, and that's what we'll be chatting about a little bit today. Okay, so when it comes to education, yes, we need to educate them about the risk they have of certain conditions and developing that, so on and so forth. But we also need to educate them on what they can do in the meantime. The 365 days or 64 days that they don't see us, hopefully, unless they have problems. But yeah,
You put everyone on 1 year recalls.
Everybody, yeah, everybody, or whatever they would call it. You're so pedantic, honestly.
Is it a leap year next year?
364 and a quarter days. Okay. So, Mehdi, you also have water in your mouth. Tell me, how would you approach educating a patient on things that they can do to maintain or manage their eye health in between tests?
Well, it's a matter of. So I'm guessing, obviously, we've done the explanation part. So I've already discussed what AMD is. Let's say for a patient with AMD. Yeah, but I'm saying that's probably the easiest example that you can give at the moment. So they know obviously what condition or problem is going on with your eyes, basically. It's just a matter of discussing about how to manage its progression or even treat it if you can, with cases like blepharitis and dry eyes and that kind of thing. In that aspect, I think it's kind of gauging the amount of worry that this patient had at the start. So like someone can come in being like, I feel like my vision's gotten worse. They can quite just distraught about it. Or someone can just be like, sometimes I have a bit of dryness, that kind of thing. So it's managing that and also discussing the possible outcomes on what happens when you do and when you don't manage it at home, basically. So like in an example of AMD, you'd be like, well, AMD, dry AMD in your case, let's say, as a condition is something that progresses regardless. What we're trying to do is to help slow that progression down for you. The best way you can do it is with diet and exercise. So leafy greens, if they're smoking, like quit smoking and that kind of thing. But you'd also want to mention about what would you do when it does get worse. I was like, well, if you feel like it's getting worse, here's your grid. I've taught you how to use it.
Stick it on the fridge.
Stick it on the fridge. And come back if you notice any development. I sometimes even tell them, like, when you do it, just draw around the bit that it is, and then when you feel like it's getting worse, you check and see if it's worse. And if it's worse, come back and we'll have a look.
If they're drawing something new, come see us anyway.
Huh?
If they're drawing something new, regardless.
As in if they
I'm saying like as a baseline, as a baseline, do that as a drawing, and if it gets worse, come back. So that's something that I guess is discussion, because you also want to discuss what AMD with someone that has the dry form, because they need to know what to expect. 100%. So that's when you're discussing with potential conditions that necessarily don't have a treatment. Do you know what I mean? It's kind of like
on that topic before you move on.
Yeah,
I feel that it is super mood lifting when you have a patient and you tell them that there's something that you can do. You don't tell them this is just going to get worse, deal with it,
Yeah.
So even if it's something that won't have the biggest effect, like, okay, have your leafy green vegetables.
Yeah.
Sure, it's proven to help. I'm not disputing that.
Something that I do say that I think helps patients is I say, although we can't stop its progression, in most cases, the progression isn't very severe. because in most cases it is not everyone ends up.
As in, with the progression of AMD, there's a very clear border at which point it becomes bad, which is wet.
But not only about like 20% of
Exactly.
patients get that kind of GA, low vision, dry AMD kind of thing.
So what you're saying is that
So,
there is a there's a gradual decline.
Yeah.
We're trying to reduce the gradient, but there's a big drop off that we want to stop from happening
exactly.
within your lifespan. As long as you're here,
Basically.
as long as you're with us, we don't
Yeah.
want it to go wet.
Yeah.
So this is what to, and it's like Usman said, is about for the patient. Obviously, they've just been told that it's not the most flattering thing, which is you've got your old and you've got old people eyes.
And
That's what they might hear when you say it's an age-related condition. They say, "Oh, this is my old age coming to make me go blind."
Yeah.
And for you to say to the patient, "Hang on a minute, here's something you can do. Take the control into your own hands." Is very uplifting and very empowering to the patient to have that control in their own ocular health.
Because ultimately, it is losing battle, AMD. Or something like that. So to tell patients,
at least dry AMD is maybe not wet.
Well,
wet AMD is a lost about.
But yeah, it is, and it's not just about AMD. It's about other things as well. It's about myopia management. It's about things like these. You can tell them, listen, likelihood is genetics and luck and all of that, so on and so forth. But there's some things you can do. We're not just going to let you be a victim to your scenario and to your environment.
Exactly.
There's things that you can do to help that. And I feel like that, giving the power, however much it is, back into the patient, which is what we're discussing today, I feel like that is really powerful.
Definitely, 100%.
Because a compliant patient is much better, is going to have better outcomes than a non-compliant patient. Any day of the week, you see the people who walk in as a newly diagnosed diabetic with all kinds of hemorrhages. If they had been more compliant, they might not have been as bad.
Mm-hmm.
The patient.
In all likelihood, they wouldn't. I mean, we can't say in the individual scenarios,
but in all likelihood, they wouldn't. As a well-regulated, well-controlled diabetic who's taking the medications on time, who's keeping the sugars under control. Whereas somebody whose sugars are up and down is going to be a better outcome. So it's about telling the patient, when you control your diabetes, you will reduce the chance of bleeds at the back.
The one caveat to this giving control to the patient, nice simultaneous drinking of water, by the way. One caveat to this giving control to the patient is the fact of managing expectations within that. I think it's very important to, although you can say you have this degree of control over how your condition progresses, you need to understand.
We need to be realistic.
We need to be realistic that the myopia with this myopia management glasses that you're going to wear, it may not work as well as we hope it to do, or the AMD may still get worse.
Well, with myopia management, what you're saying to them is, you will still be more short-sighted at the end of this, but hopefully not as short-sighted as you would have been. And you've also got to say with myopia management as well, there's another expectation setting, which is, I'm not going to be able to look at you in 5 years' time and say, look, we stopped it by 50%, because if
I don't know what it would have been.
I don't know what it would have been. And if you say no to me, I can't tell you what it would have been if you had said yes to me. There's no way of knowing, and it's a really sort of difficult situation that you're in there, isn't it? Because you're asking them to put their trust in you, but you can't tell them.
It's definitely
whether the outcome is better or not.
It's definitely more difficult with myopia management, because you're trying to get them to accept that they need this type of lens, this product that's costing them upwards of £250 per eye test, basically, for something that may not even work.
I find the lack of knowledge and education over simple eye conditions just mind-blowing. For example, people are almost more ready to accept that they'll need a hip replacement than they'll need presbyopic glasses. Something presbyopia which will affect everybody. Everybody.
It's bizarre that it's not more known.
Like, it's not. People don't just expect it. People expect certain things. They expect their hair to go grey. They expect puberty to happen. They expect these things because it happens to every person. But why
is presbyopia?
Presbyopia isn't a thing. Everybody will need a different management system for their reading, whether it's taking off your glasses, short-sighted,
putting on your glasses,
if you're long-sighted, or so.
Latent hyperopia.
And sure.
It's a whole kind of different kind of worms. That is, your distance is getting worse and your reading is getting worse simultaneously.
Except your distance isn't getting worse. Your eyes are just getting older.
Yeah, you just can't.
I have to say to them, it was always like this, but your eyes have been working double time until now, and now they're starting to give up a bit.
What do you mean they started to get worse when I was 10?
Well, they're retiring.
And like cataracts, the amount of times that patients will recoil in horror when I mention cataracts, and
Right, calm down.
it's like
because they've obviously heard the horror stories of my grandma had cataracts and she went blind, but
Your grandma was 90
but it's
years
just
ago.
but it's just the lack of education and awareness over
Yeah,
these certain
definitely.
things. It's like, listen, cataracts, the most common eye operation in the UK.
Yeah.
Like
I
everybody
think it's in
gets
the
it.
world, Cataracts.
Well, yeah, sure.
Yeah, I wouldn't be fast to say it's
reference for that claim will be in the description.
no,
Yeah, you got to find that.
You've got
But
homework.
but yeah, it's like if we all live long enough, we'll all get cataracts.
Yeah.
Yeah,
I think I've already said this previously in like another part. I always say it's a when condition, not an if condition. And that always seems to calm them down because they're like, oh, okay, it's not just me.
I've started telling them. I tested the eyes of my neighbour, 84-year-old lady, and she's got cataracts, but she's not having anything done about them. She's still 6'7", 6'9". So what I say is, some people in their 60s are, losing the sight and have to have it done. Some people, my neighbour's 84 and she hasn't had it done yet, and she's absolutely fine. So it varies.
Yeah, definitely.
So it's all well and good that we've educated the patient on all of this. I think the next big thing to consider with patient empowerment is, now that they've got this knowledge, to empower them to actively take decisions. And I think sometimes what can seem like a bit of a hard pill to swallow is that the decision is ultimately in the hands of the patient.
Yeah.
And as much as we want them to do and go down a certain route of management or treatment,
what we think is best for
what
them.
we think is best as healthcare professionals,
Yeah.
that may not always align with what the patient wants.
Yeah.
Sometimes you do get the patient who will decline treatment, who will decline referral, and ultimately it is a difficult thing to come to terms to, but you have to respect and
yeah. I would say it now. Sometimes the patient's just flat out wrong, but it's their eyes, their decision, their body. We can't.
Yeah.
It's like you're 6'9" without 6'4" with, and they're like, no, I'm fine. I was like, okay.
To some, I mean, I say to all extents, the patient gets the final say.
Oh yeah, absolutely.
So it's just that's basically it.
Exactly.
Yeah.
I've actually had a patient that they had wet AMD. They were like 90 something years old. They had wet AMD in one eye. The other eye was just dry AMD. I was like, I need to refer you on to the hospital. They're like, I don't want to go to hospital. I'm done with that place.
Yeah,
so they literally declined. They literally just declined it. I was like, you need to know that it will get worse and will be a point where it's untreatable. And they're like, yeah, but I don't want to go. I was like, fair enough. We'll see you. We'll see you next year.
You write a paragraph explaining what happened.
Yeah.
And then you just kind of have.
Yeah, if they do decline, you need to write that down.
You need to write as much as you can. But yes,
I think
that's.
But
that happens a lot with cataract as well.
Yeah, it does. But the thing is, cataract is a little less of
because it's
always come back next year, it gets worse. But the thing with, because I think all practitioners know that the patient gets the final say, at least in the UK anyway. the patient gets the final say. But the thing is there's more to it on the practitioner side, because then we're liable for that patient not being treated.
Well, what are the steps that you take when a patient declines referral?
Well, the easiest way is to write it on your notes.
No, of course you noted that they have declined the referral, but these are the things that you've got to do first. You've got to make sure, and it goes back to the first point of making sure they've got an informed decision. You've got to tell them, if you don't take this referral, what's going to happen as a result of it. Because there's all well and good saying you've got wet AMD, your vision has gone poor, let me refer you to the hospital.
Yeah.
Rewind.
Do you have a client gone?
Even before that, you need to understand that you need to make sure they understand what's going on with their eyes.
Of course, yeah.
Rejecting something out of ignorance.
Yeah. Exactly.
Fear or ignorance.
Yeah. Exactly. So you've got to tell them, first of all, what's happening, why it's happening. Then you've got to ultimately give them the prognosis. If they say, I don't want to be referred for glaucoma, you will say to them, if glaucoma is untreated, your visual field will shrink and you will eventually lose sight if it progresses long enough. If you don't have this cataract taken out, your visual acuity isn't getting any better. No. It will continue to get worse.
And you will lose sight.
Those are the things, making sure that you make them aware of what's happening, why it's happening, and what will continue to happen if they decline referral, and the treatment options. You need to address why, first of all, why they're declining the referral.
Definitely.
Some of it comes to patient expectations and lifestyle. If somebody is 90 and they say, I don't want to be seen for my wet AMD, they've got very poor vision anyway, and it's just turned from dry with intense geographic atrophy to wet, what difference is that going to make to their lifestyle when they've got no mobility anyway and they don't do much? It's as harsh as it sounds. It depends on ultimately what the patient.
It does. So, like, obviously, we as practitioners and optometrists, we like, okay, so you have this problem. This is the best thing that we can do for you. But it's good for us to be able to sympathize as to why patients don't want that certain treatment. Just like you said, that patient who's like 90 years old on a wheelchair, they're not very active, they don't do much reading, and they don't want to go to the hospital, go through all that essentially trauma of having injections and
exactly.
surgeries.
You've got to consider what the actual treatment would involve if it's so invasive and so intense.
So it's not. I mean, it's not nice to talk about because like
Quite
you want patients to improve their vision with that, but it's something that happens,
and it's not even,
and that's not uncommon. It does happen.
Yeah, no, and the thing is, like, sure, we're picking up extreme examples, wet AMD patient treatment and all that, which hopefully you don't see ever, but you may see, and again, within the patient's rights. But it can rear its head in much more,
subtle ways.
Exactly, it can be somebody, a hyperope who's just now starting to lose some sharpness, and it's like, okay, you're losing 2 lines, we can make this better, but I'm not used to it because they're 38 or whatever, and they don't want to. Or it's someone who's who's having to hold things further back for their reading and having to squint, and oh, it's fine, you turn on the light and it's all okay, and you're like, hold on, you don't need to do that, you're N8 without 4 with. And it's like, look at this, and for us it's like,
it's a very clear, night and day difference.
It's part of the fun.
Like, why are you not taking these glasses?
But the fact is that balance of what's more inconvenient to them, it's more inconvenient to them to wear their reading glasses than it is to squint, hold it further back, and turn on the light.
Yeah.
And that's not our decision to make.
When it comes to glasses, I think in some cases it is down to education of them being not educated enough about the requirement of glasses to improve their sight. The best way for glasses to educate them is to do without and with. And then that's when you know that they know what they're going, they know what they're declining basically. They know what they're saying they don't want because you've actually shown them.
Yeah, so you make sure they're aware.
Exactly. That's the best way to do it. For glasses.
That's part of it. You have to make sure they're aware of what they have, what they don't have.
The other thing I would say that's another sort of condition to you accepting the fact that the patient has declined whatever outcome you'd wanted for them, is to leave the door open. If they've said no to cataracts this year, they don't need to say no to it next year. They don't have to then say no to it next year. They can always come back with those wet AMDs that decline anti-VEGFs, and you can say to them, whenever you're ready, come back and let me know.
The thing is, wet AMD is that there is a window for it, though.
There is there's a window for obviously the benefit of the treatment, but there's never a window for going to the hospital for the first time to be seen and registered.
Yes, but there is. But the thing is, if that window's passed,
of course,
the hospital won't treat it.
It might be they go home and tell their wife what they had at their
NHS, and then the wife
no,
that's fine.
Obviously, Mehdi, meaning like that's part of the advice. Just be aware of, as he mentioned, once they refuse, to make sure that they're aware of what risks there are.
Yeah.
So he's not gonna be telling patients, oh, in 2 years.
No, I'm not saying that. I'm not.
Obviously, something like that.
You're given the time frame, obviously, but I'm giving you an example. For example, somebody who was I saw somebody who was diabetic. Well, no, they weren't diagnosed diabetic. They had intense proliferative retinopathy.
Nice.
But they had anxiety and they were afraid of needles and blood tests. Yeah. They had not been to the GP for the diabetic blood sugar test.
Yeah.
And I sort of tried to explain to him that there are other ways they can diagnose you. They could do a urine test. They could do other things to measure your blood sugars. It is really important you get diagnosed. He was sort of flat out refusing any kind of involvement from the GP to get a diagnosis of diabetes. What I find that you can do sometimes is you can write a letter addressed to the GP, print it, hand it to them in an envelope, say if you change your mind, the door's always open. No, and you write on the letter, the patient has declined referral, I'm writing this in case they change their mind, and then you leave it in the patient's hand. So they've got the letter in their hand, and if they say no, they say no. That's ultimately
that's interesting. I think no, you're definitely right about that. And when you said the doors was open, I was thinking about the you saying like someone.
If they change their mind on Christmas Day and wish up and
no, I was thinking like, oh, you have wet AMD. I'll come back next year. We'll sort it out. I was like, you can't really do that with it.
You never do.
No.
that.
I think the most likely time, I don't have any studies to prove it, but I'm assuming that the most likely time they're going to change their mind is within a few days.
Yeah, because they've discussed it with
their wife and got told off.
Yeah. In most cases, yeah. The only like condition where delaying referral, I'm not going to say beneficial, it's something that patients tend to do, and it's not as concerning for us, is I guess cataract, especially if someone's like a non-driver. You do get those few patients that are like, oh, I don't want to do it until it's like really bad. And I'm like, you can do that if you want to wait another year. We can check it another year, but like, you also need to discuss that there is a point where the risks do go up as the cataract gets worse. Because the density, there's a certain
in
density.
surgery.
Yeah,
Okay.
there's a density of that cataract. So obviously, if you have like synechiae in the very high, very high,
or even the fact that once you've got a really, really dense cataract and you're 75 and you smoke, there may even be some AMD going on, but I can't see what's happening on the OCT because your media is so dense.
So there's a matter of discussing that with the patient as well. Is that like, yes, okay, we can leave it next year to see how it develops and things like that, but you need to be aware that we can't just keep doing that, because then it will make my job harder because I can't see the back of your eye. It'll make the surgeon's job harder because it's tough to take it out.
Also, it's like, their COPD might be getting worse, or they might be getting weaker.
Yeah,
the heart might be getting a bit weaker, or something like
exactly.
that.
So you might, need to do in the general anesthetic. So
exactly. So there's a matter of discussing that with the patient as well if they decide to decline the referral for cataract specifically.
Yeah. I find that it's driving is such a good convincer, because it's the case of we don't really have any legal eyesight requirements outside of occupation other than driving, to be honest with you.
There's no threshold that you're like, oh, you can't do this anymore.
Exactly. Everything else is just personal preference if you're not manually driving.
If you want to get a bigger TV, movie chair closer.
It's just like, if it works for you and you're not driving, I guess.
I guess
okay,
fine.
then. You have at it.
Yeah.
But yeah, when
it's frustrating though, isn't it? When you could, you're 6'15", but you don't drive. You're happy with it. I want you to be 6'6".
Yeah.
You could be, and
you have the potential.
You have so much potential. It's quite a difficult thing for us to come to terms with, but I mean, ultimately, that's what it is. It's not in our hands. It's not our decision to make.
And again, it might be a relatively easy decision for us, because we might not find classes as inconvenient as somebody else would, or we might not find the treatment as scary or inconvenient.
Yeah.
Maybe I know, because I have locum in rural places. Sometimes it's super difficult to manage lifts. Sometimes if they don't have any family nearby and they need to, like, they're not going to be driving back from the cataract operation, they have to be up front and have to manage that. It's like, listen, I understand it's challenging. I understand you can't drive yourself. I understand you're taking care of your husband or something like that. So it's not often just, I don't want to wear glasses.
Obviously, there are some, like, a lot of clinics, they send out
but in these places, like,
it's more difficult to
you explore your options, and if that's an option, you tell them that that's an option. If it's not an option, then
definitely.
But I was just using that as an example. It's not always as simple as patient not wanting the aesthetics of glasses or something like that.
I think another point that's I think valid to bring up in this discussion is when you have patients that you need to manage or refer, but that specific patient doesn't have the capacity to consent.
Oh, yeah, that's interesting.
For example, like someone that's under 16, or let's say
not under 16.
Technically.
Gillick's
as a matter of fact, actually.
Gillick's competency.
Everybody knows what Gillick's competency is. We're not going to go into it. A 15-year-old who says, I don't want my mum in the room, makes their own decisions. That's fine. The 3-year-old who's got amblyopia,
retinoblastoma.
Yes, that is not the person you ask, do you want to go to the hospital?
They poke your eye and take it out.
They're going to shine lights at you and give you glasses.
With retinoblastoma? Let's give you glasses.
Shine lights.
Make all that. I'm going to hack to an extra and pop you on your way.
Yeah,
They've got
or
really cool
for example,
symptoms.
maybe not just under 16 though. You can have more like nuanced patients that can't
Mental health problems,
exactly
learning difficulties. You could
yeah.
have elderly patients with dementia,
Yeah.
things like that. And
So
then,
how would you like address that in terms of making sure that you have correctly educated?
well, firstly, if somebody's got limited capacity for consent, you may not have the best objective. So you've got to set the expectations in terms of, for example, AMD. Your mum here isn't going to be able to tell us when she's getting distortions, or well, she might, but she won't be able to in most cases, accurately plot an arm's-length
or get in touch with us or something.
Or get in touch with us. But you've got to be on the lookout for these things. Or when they've got the wet AMD, you've got to explain to somebody else entirely what's happening, inform them, educate them, let them know the risks and disadvantages, and then let them make the decision if they're the appointed decision maker. Now, when it comes to these kind of situations, especially with the elderly patients who 90 years old with dementia, the question of what their expected outcomes are and what they need vision for is obviously going to be slightly different. I've seen a patient who was well into his 90s and he was sort of almost basically non-verbal, very little movement, severe dementia, and the conversation I had was, he's got limited mobility. I can't get a great look at him on the slit lamp. I've tried with my off-pal. It's not a great view. I can put some drops in and we can have a look. But in this decision, forget referrals, internal decision making. Would you like these drops in? They sting. They will make his vision more blurred than what it is. I don't know what his vision is at the moment. It's not great. It'll make everything a bit wider. He'll be more sensitive to light. You're going to be here for another hour.
You're really selling them.
However, this will allow me to have a better look inside of his eye. I can check for things like glaucoma. I could check his retina. I can have a better look. We've not got great scans or great photographs. It will allow me to have a better look into his eye and possibly even get a better refraction if he's had some kind of dilating effect. You could get a better view on ret, for example. Give the full advantages and disadvantages. That patient, well, the son for the patient said to me,
basically pivoting your advice over to the person responsible.
Exactly, but then you've also got to remember what he said to me was, my dad's 90, he can't read, he doesn't do much, he doesn't watch much TV, he just has some glasses that makes things vaguely better. I've got a previous RX with something in there. He said, can you just give me the same again? I don't want to have it dilated because if he gets dilated, he's going to get upset, he's going to be hard to manage here. At 90, he's got maybe a year, given his health in that particular situation, the son said to me he's got like a year or two in him. If you pick up glaucoma at that stage, and it's in its very early stages, what are you going to do about that glaucoma? It's not going to progress between 90 and 92 in such a way that's going to significantly affect his life. So I'm not too fussed, he said. And ultimately that's his decision as the son of the patient, the main caregiver for the main person responsible.
It becomes a little more nuanced when it's two adults. So someone
that's not your problem.
I don't know. No,
for them to work out two parents or something.
No, not in that aspect. I mean, like obviously, someone with learning difficulties with a carer is obviously straightforward. But someone who's like got dementia, obviously, you can't assess how much it's affecting the patient with dementia. Obviously, so you might have
to just do your best, haven't you?
No, I understand. But I'm saying like someone that has dementia, it might be like mid stage, so that they're able to understand you and things like that.
Of course.
But obviously, the decision making is still with the carer, because they will forget what you've told them. So they won't. They'll understand it, but then they'll forget.
But then in those sort of early to mid stage dementia, they may have some.
They have the cognitive capacity to make the decision on the spot, basically.
Of course, but then you've also got to remember that because some of these decision-making conversations you'll have towards the end, you've got that full eyesight test, history and symptoms to try and assess yourself. It's going to be a very broad, very rough assessment, but you've got to see, are they able to retain information?
You'll know by history.
You'll know by history, and somewhat in the refraction you get an idea. If they're saying to you one to every single question, then maybe they're not as
But I'm more thinking about of when you would discuss it with the patient for the carer to hear. So that's something that I do is in some cases as well. Is the patient understands what you're saying, so for them to feel like it's their eye test, if you're going to empower them, I think it's important that the patient feels like you're discussing this with them and that you want they're in control.
And then you look over and nod to the child.
Yeah, and then you look and then you look over to the carer and be like, this is essentially what we think it is as well. Like, what do you think about it as well? Would it be easy for you to arrange, like, I don't know, the patient to go for the cataract surgery? Things like that. I think it becomes a bit more nuanced when you have two adults with one.
I like to, in those situations where there's some limited capacity but some capacity remaining, I like to make it a group kind of conversation, a group decision. So I'll talk to the patient primarily, and then I'll look and I'll say, what do we think? What are we thinking about the cataract surgery? Do we want to have it done? And I'll address them both.
Oftentimes they'll chip in with inputs themselves. Be like, oh, your sister had the operation done. Remember, and she said that she liked it. So the carer themselves will often be involved because they're used to being involved. In certain scenarios, there's
a lot of grey area that you have to kind of navigate.
It's a matter of gauging how much input the carer is actually putting in when they're discussing with the patient and seeing how much capacity of response that patient has.
And not just by the fact that they have a carer that in and of itself
exactly,
because the carer could be literally the driver for the day just because they have a bad leg or something.
Or in a lot of cases they could literally just be the patient's ears.
Literally just they've got a hearing aid and they're literally just there to
reiterate what you've just said
a bit louder and in a way that they're
but like at that point, that although there's a lot of discussion that you have with that carer because the patient's hard of hearing, that patient still has the cognitive capacity to respond. Therefore, they're still the decision maker.
There is literally in that situation, you're basically dealing with the translator.
Exactly.
And a translator doesn't make the decisions.
Exactly.
It's obviously it can sometimes be a bit of a harder pill to swallow when you're dealing with somebody who is, say, advanced dementia, or like your patient in their 90s, or a very young infant child who clearly doesn't have the capacity to make educated decisions for themselves.
Or just response,
And you have to redirect your discussion and the output with their guardian care or whoever it may be. And it is harder when there's advice that you think that should be followed and it's not being followed, but it's not coming from the patient, just from a personal perspective, just from a personal point of view. If it's somebody refusing a cataract operation for themselves, it's not ideal.
It's easier to accept than when the carer is doing it.
Exactly, and of course you have to respect them both equally. But in the certain situation, when deemed necessary, but it is a bit harder. It reminds me of this patient.
This is out of the scope of negligence and abuse, though.
Of course.
Oh yeah. If your patient is like relatively competent, and then you say, "Oh, you're reaching 6'9". Would you like to think about your cataracts?" And then they say, "No, he doesn't want that done. He's okay. He doesn't need to see where he's going. He's fine.
He drives."
As they're like reaching for the purse, then that maybe speak to a colleague.
If you have any doubts or concerns,
as he grabs the collar of the patient.
If you see bruises, then that is maybe.
Sorry, you were going to say.
We're talking about non-safeguarding.
Make sure you're up to date with your safeguarding training.
Do your CPD.
Dosette level 2. If you've not done it, jump on it.
I did it the other week. It was really good.
It's interactive. It's fun. Yeah.
You were mentioning a patient.
I had a patient last week, young infant boy, and about roughly 5 or 6. So this wasn't the first test. The test prior, I actually just come up from signing off his elder sister's glasses.
Okay.
And myopic family. Okay. The notes prior said that he didn't have glasses. The optometrist advised glasses. The father did not believe that he needed glasses and thought that it was just going to be a scenario where he'll get glasses and he'll wear them for the rest of his life. He's not complaining. He can see everything fine. Blah, blah, blah. He doesn't need glasses. The note said it wasn't in the refraction area. It was in the
advice
management. It was in the history area.
Oh, okay.
But regardless, wherever it is, that's not
it's
important.
Still there.
Exactly. About -2 myope.
Oh, okay.
Definitely advisable.
Yeah. But the sibling who's a myope who's already wearing glasses.
Not at that level, but I think that put the dad off even further. They're like, "Oh, I don't want him to end up like his
I don't
sister.
want this one being like this too."
Exactly. It's like he's fine. She wasn't. She was complaining. Girls are a little bit more switched on, obviously. But he was complaining, and he wasn't complaining, so on and so
Yeah.
forth. And that day, I found his myopia had, unsurprisingly, considerably advanced. I pulled out a trial lens, showed the father that this is his vision. And the father was very confused, like, he's not complaining.
You put a +3 in front of the dad.
Because he doesn't know what normal is. That's
+4.
It was about -350, and I assumed the dad didn't wear glasses, he didn't need glasses. I assumed he might have had a small hyperopic prescription, so I just bumped up a little bit.
Oh yeah, sure.
But
he gave you latent hyperop vibes. You looked at him like, oh, you're about a +50.
Absolutely.
I'm not taking any chances. If I give you a +3, you say, oh, that's great.
Wait, this is how he sees not.
When was the last time you had night test?
It's but yeah, and that was a case where I was a lot more, but that does stray into negligence a little bit. That was a lot more pushy, but thankfully it wasn't a hard conversation to have. The dad was remorseful.
I feel like if after you had done that, they were still adamant that he doesn't need it, then I think it would start to be
more.
That's where
thankfully I didn't have to make those decisions. I didn't have to get other people involved.
And that's really the importance of the education. Because if you hadn't informed that father of it, and you said, "Oh, he's even more short-sighted. Do you want to buy some glasses?"
Yeah.
If you did it in that kind of a way, then that's not informing the patient properly, and he might have thought that you were just trying to push get a good conversion.
Just another one.
Exactly, and then that father would have been negligent, but it wouldn't have been entirely his fault. It would have been partly your fault in that situation.
Exactly.
So that's
definitely 100%.
Just in that conversation, one thing I like, because we were recording this in December. One thing I like about this time is because clinics are quieter.
Yeah.
I feel I've got so much more time with patients.
Yeah.
we all have enough time with patients regardless. But over here, you can slide back and go into a bit more depth.
You have less of the I'm running late kind of thing. Like
I was running late. Mind you, the pretest.
Like when you have an empty slot after this patient, like you're like, okay, I can spend a bit more time like discussing it like in full length with them.
Yeah, I've had in the last week I've had multiple patients inside my room for over 40 minutes, and it's just because one patient I remember I had a half-hour chat about laser eye surgery, the pros and cons whether or not they want to do it. Another patient talking about the varifocals, okay. But anyway, side point. I like this time of year not only because it's quieter, it's a bit easier, but
you should get cancelled.
True. But yeah, the
bit more breathing room.
And it was just in that conversation with the father that clues started to pop up.
Yeah.
And he's like, oh, he tells me it's because you're sitting too close to the TV. I'm like, hold on, he's myopic. He's sitting close to the TV because he can't see. Yeah. And I asked the child, like, when you sit back, like your dad tells you, is the TV clear? Is it blurry? It's like, oh, it's blurry. When you sit close, it's clear. It's blurry. It's clear. I'm like, he just wants to watch the TV in clarity. Now with the new glasses, he can, because it was part of myopia management. Don't be too close. 30 centimeters, 30 minutes, so on and so forth. I was like, sit back, and it's like, oh, he doesn't sit back, so on. So these types of things in conversation, you can address these issues and these concerns and these points.
One other discussion. This goes back to the first point, is management when there isn't a problem. So pre-myopia management, basically, it's like when you expect that something could possibly happen in the future. So you'd want to prepare the patient or the parent.
The 4-year-old with a plano.
Yeah, you'd want to make them aware of a certain condition that may happen, so they're not shocked when it does. I think that's also another part of education. That's something that we didn't really touch on.
And it comes into that sort of setting expectations, doesn't it? Of telling the person with an early nuclear sclerotic that is going to get worse. Telling the patient with plus 0.25 at 4 years old that they might be more short-sighted.
Both the parents are -6.
Yeah.
Like, listen,
yeah, exactly. Just even family history glaucoma with suspicious-looking discs that are fine and the fields are fine today, but this may progress.
Yeah.
Maybe.
Yeah. But just make sure the patient.
It's letting the patient know what's involved. In certain cases, letting the guardian or the advocate for the patient know what's to be expected, setting realistic expectations and then following through on them.
Definitely.
And, following through on them, that just comes down to having appropriate recalls, having your follow-up conversations. If somebody is convergence insufficient, bringing them back in for the follow-up, seeing how they're getting on with the pension nose exercises, even if it is just a call, just to say, how's it going? how the symptoms, how you're improving, and just keeping an eye on them.
Definitely.
These are things that will be very relevant in your guys' place, because as a resident you have that a bit more
continuity.
But even not as a resident, when you speak to a Caucasian female in her 20s that's got multiple sclerosis, you need to advise that, hold on, you're at higher risk of developing optic neuritis and other things. When you talk about a -7 myope who's talking about, oh, I'm going to go to Australia, going to go bungee jumping, you're like, hold on, so on and so forth. So even in that moment, in that time, there's lots of advice that you can give that what will potentially happen in the future, what they're higher at risk of.
Yeah.
That's it. Thanks for joining us for another episode. Hope to see you next time.